Welcome to the Staying Active podcast, brought to you by Active Health, Connecticut's premier preventive health center.
All right, so welcome back to Staying Active with Derek and Dr. Jon. I've got my radio voice going, and I'm ready for insulin resistance, specifically insulin resistance and no presence of diabetes. And so we were just talking a little bit, really thinking that maybe some people don't necessarily know what insulin resistance is, or maybe it's kind of like a vagary, they have like loosely, understood it. So you had suggested maybe we start by defining what insulin is, and then you had more things to say, I'm sure.
Yeah, I think that's a good idea. And your radio voice, may I say, sounds spectacular. So keep it up.
It's my radio face that really does it, though.
Well, we're on video, so that's people get to see your beauty if they're watching, if they're lucky enough to watch in person or through the video. But insulin. So insulin is something most people are probably familiar with the term. But insulin is a hormone that is released by your pancreas, specifically by your beta cells in your pancreas. And the pancreas is kind of a non-specific organ, meaning it's kind of like, it's hard to feel, essentially, as we kind of palpate the abdomen. It's kind of right under the rib cage and kind of in the middle, like right in the midline, is kind of the pancreas. It's this kind of fatty, slender organ that has really important functions, one of which is to release insulin. And so insulin is a hormone that is released in response to any sort of ingestion of food, specifically carbohydrates or things that release glucose into the bloodstream. And insulin sort of defends the level of glucose in the blood. So in it's sort of in real time, actually. It's kind of fascinating. So when you have a lot of blood sugar, when you have high levels of blood sugar, rather, say you've eaten a large meal, you ate a pizza from Sally's, and you've got a lot of sugar running around in the bloodstream because it's a carbohydrate. Insulin will be released by the beta cells, and that will tell certain tissues to, hey, we've got this glucose running around. Why don't we take that out of the bloodstream into circulation so we can do things with it? And those three tissues are primarily skeletal muscle, and skeletal muscle is like basically muscle that you use to move things with. It's not heart and it's not muscle in the blood vessels, but it's muscle that you can move with. You make a bicep, that's a skeletal muscle. The other tissue is liver, and the last tissue is adipose tissue or fat cells. And so insulin tells these three tissues to, hey, use up this glucose, we've got it in the bloodstream, and do something with it. And most of the time it's to store that, either to use the glucose or to store it. And it's stored either in the form of glycogen, which is mainly in the liver, or it can get sort of converted through a pathway into fat. And so that gets stored in the adipose tissue, gets stored in the liver, and not really so much in the muscle. But insulin's super useful. We term it an anabolic hormone. So if folks are familiar with things that are anabolic, like anabolic steroids, they cause things to grow or to build. And so insulin helps us build fat stores, can be somewhat helpful in building muscle, as opposed to a catabolic hormone, which breaks things down. So insulin is an anabolic hormone. So that's sort of what insulin does in response to eating a meal. To get to what insulin resistance is, you can think about it sort of, I was trying to think of an analogy for this. And Derek, I know you're a parent. I'm a parent. If you tell your child to do something once, they may listen to you and do it. If you tell
Hallelujah.
God willing, if you tell them 2 or 3 times to, hey, brush your teeth. Oh, you got to keep brushing your teeth, brush your teeth, brush your teeth. Eventually that just becomes noise and they stop listening to you. And so insulin kind of works the same way with these 3 tissues. Insulin is telling the skeletal muscle and the liver and the fat cells, hey, we've got all this extra glucose running around. You got to do something with it. But if you are not exercising and you are eating a very high carbohydrate, high calorie diet, you've got a lot of this glucose running around, and your insulin is going to be like, hey, come on, take this out of circulation, take this out of circulation, take this out of circulation. And eventually your other tissues are like, nah, I don't really feel like it. I've got what I need. I don't really want to do that. So then you have to do the equivalent of what a parent does of perhaps raising their voice. And that's when you need more insulin to achieve the same response in those three tissues. So you need much more insulin to say, hey, take this out of circulation, because the tissues don't really want to. They're like, I got what I need. But if insulin is yelling at them to do so, they will. They'll be like, fine, I'll take some more glucose out of circulation. But eventually you reach a point where these tissues become saturated. They cannot take any more glucose, or really much more glucose, out of circulation, and the blood glucose will start to rise. And that's where we see this distinction of, pre-diabetes and then into eventual diabetes. But you can have a normal blood sugar, as you alluded to in your question. You can have a normal blood sugar and still have insulin resistance. What that means is that you have your beta cells in your pancreas are pumping out much more insulin to achieve the same result of getting the glucose that you have in the bloodstream out of circulation. And so that is sort of the spectrum when we talk about metabolic disorder and high blood sugar, hyperglycemia. The sort of first thing we see, the first abnormality we see, is typically this insulin resistance, which then will move towards pre-diabetes, which then will move towards diabetes, which then will move towards very poorly controlled diabetes, and nobody wants to really have that. So that is a long-winded explanation of insulin and insulin resistance.
I certainly hope for everyone that it is clear that we do not want diabetes, that it is ideal to not have diabetes. And so I don't think we need to necessarily frame the why for the problem. If we go down this road enough, diabetes is around the corner, and that's bad.
Right. And specifically type 2 diabetes, because type
Yes.
1 is autoimmune, typically seen in children or younger people.
Sure.
Which is not, that's a separate pathway to get there. This is
Certainly.
type 2 diabetes, which is, we don't want that.
We don't want to allow ourselves, or our habits, or, lack of information to allow ourselves to manifest or let type 2 diabetes develop, essentially. So, all right. So without kind of like grinding that out, I don't want to go nuts on that, but I do want to talk about, one of the more obvious questions to me is like, why would that happen? Why would you have insulin resistance while, fasting glucose and A1C might look normal, right? Why, those are your markers essentially, right? To determine whether or not a person is diabetic. If those things are like quote unquote considered normal, what's going on, and how would one determine that they are insulin resistant?
So that's a great question. Blood glucose can be in a normal range. Your A1C, which is a 3-month average of blood glucose, can be in a normal range, and you can still have insulin resistance. And the way this happens, which we sort of alluded to, but the way this happens is either you don't use up the sugar you have in the bloodstream, or you take in too much. So it's either an input problem, too much input, or too little output. You can think about it that way. So the too much input is fairly straightforward. It's you're eating way too many calories, typically way too many carbohydrates, and protein actually can get converted into sugar too. So sometimes we see very high protein diets sometimes leading to this, but it's much more rare. Typically we see it with high carbohydrate intakes. There is no pathway to convert pure fat. If you are on a pure fat diet, zero carbohydrate, there's really no pathway to convert that to blood glucose. But for all intents and purposes, that's not a diet that anyone can sustain. Even people in really strict keto are taking in some carbohydrates. So too much we have too much carbohydrates in the diet, too many calories, that will certainly cause insulin signaling to ramp up. On the other side, you're too little output. What I mean by that is if you're not for lack of a better term, you're not using up the sugar that's in the bloodstream. Sugar is essentially energy, right? That's how our body can convert that through breaking down certain chemical bonds into ATP, which is the energy unit of the cell. If we have, if we don't have enough of um, of glucose in the system, we won't have enough energy to do what we need to do. But if we have way too much glucose and we're not using it up, that will eventually tell all these three tissues, muscle, liver, and adipose tissue, hey, we're good. We don't need any more glucose, so we'll stop listening to the signal from insulin. So the way you use up glucose, and the muscle is really good at this, is you work out, you exercise. Typically, this is something that where you're moving your body above and beyond kind of, you know, it, everyday, day-to-day life. So this is dedicated exercise. Strength training is fantastic at this, kind of building muscles, building, to use a sort of an antiquated analogy, but building a bigger engine to then burn more fuel. But also any sort of cardio exercise is going to do this as well. But basically burning the calories, your muscles are really good at using up the extra glucose. And so that's a really good way uh, to kind of make sure that you're using enough, you have enough output of energy. And where you're really getting into trouble is you have a lot of Americans who are doing both. They're A, taking in way too many carbohydrates and calories, and B, they're not using up enough carbohydrates and calories, and that compounds the issue. And we see really rampant insulin resistance and and then, of course, higher rates of prediabetes and diabetes.
Sure. And I think this is an appropriate time to just kind of double down on something a little bit. You had mentioned the utility, right? Using up the glucose, right? Using up to keep things simple, using up the carbohydrates that you ingest, right? That's kind of a delicate balance. And just for our nutrition people, bringing up the idea of using like cardiovascular exercise for like using glucose is great because it's highly effective. However, it only works if you do, which is a nice Arnold Schwarzenegger quote, right? It is completely dependent on you going to perform the thing, which brings up sustainability, right? When you increase your skeletal muscle mass, it works for you no matter what, because it needs energy simply to exist, which, in my opinion, is an extraordinarily sustainable approach for utilizing more glucose and more carbohydrates. So one of the first things I always tell people is like, look, you've got, this pre-diabetes thing going, you've got all these things outside of what's happening with you medically. The number one best thing that you can do is increase your skeletal muscle mass to whatever your genetic threshold is. Gain as much muscle as your body will allow without doing anything drastic, right? And then of course, leveraging extra activity, walking, running, step master, whatever you want to do, right? Only benefits you otherwise. But you have to do the work for the cardiovascular training. And I think that's a good point to just really drive home. For people who are looking for solutions, that's a really tangible, practical one.
Absolutely. Yeah. I mean, it's almost a cheat code in that sense. I mean, it's like in investing, right? You invest your money,
Right.
it'll compound and work for you while you sleep.
That's right.
Similar analogy to building muscle. If you have a high muscle mass, it'll work for you while you sleep. And we see this in many studies where patients with a higher skeletal muscle mass have a lower incidence of insulin resistance. And so this is a really an important and to use a Latin term, a sine qua non, meaning like you have to do it. It's a must for helping with insulin resistance.
Yeah, and you alluded to what I would kind of just simplify as like lifestyle as like a big factor for insulin resistance. We're really fortunate in the States. We've got an abundance of stuff and things, right? We've got a lot of food, we've got free time, we've got pretty good standard of living for most
Hmm.
people. And that seems to generate this excess, right? Taking in too much and then not burning enough, right? And that, to use your investing, you're kind of reverse investing in that way. You're kind of going in the opposite direction. Um, so I guess can we dig into that a little bit more, like some of these lifestyle things? Because it sounds a little bit, and I'm not trying to be too aggressive here, but it sounds a lot like this is a disease of plenty. It seems like this is something that people often do to themselves.
Yeah, and a key point in this is that insulin resistance is entirely reversible.
Mm.
Once you're on that track, you hop off anytime you want. It is not you're not locked into a disease or diagnosis if you have insulin resistance. And we can get a little bit into like the specifics of how we necessarily diagnose it and how you know if you are, but we can talk about that later. But it is absolutely a disease of plenty. And it's unfortunate that in this country, in the United States, we've done a very good job at making sure that it's difficult for people to go hungry. The cheaper foods are typically the ones that are the most calorie dense. In fact, I was at Target the other day, and Coca-Cola is cheaper than water by unit volume, which is kind of insane. It was on sale, and
That's
so it's
insane.
yeah, it's easier for people to get Coca-Cola, which is obviously very calorie dense, high in sugar, than water, which is unequivocally a healthier option. But if money is tight, if you're on a budget, you got mouths to feed, you're going to make a decision. That's for survival almost. And so we've made it very easy to have too many calories, especially in the form of cheap carbohydrates. High fructose corn syrup has made it very easy for us to get calories and get calories fast and get calories cheaply in the form of carbohydrates and sugar. So that has absolutely compounded the problem and made it difficult. The sort of, again, the good news in that this is reversible is it can take, relatively small changes in both diet and exercise to actually make a really big difference, especially if someone has really poor dietary habits or someone is completely untrained. That 0 to 1 step is where we see the biggest jump in improvement in outcomes. And so there's no, even if you're not going to be perfect about this, there's no reason not to start and not to try. And that's a really important point. But it is an entirely reversible disease state, and it's really just takes those two interventions of improved diet uh, and uh, better physical activity, like you said, more muscle mass.
Certainly. So I have a couple of things on this, and I don't want to trail off into the testing and everything like that just yet.
Mhm.
Um, but I do want to get into kind of like I think we're painting a pretty good picture of the types of behaviors and habits that will lead someone to this outcome. Um, there are obviously fringe cases where people outliers, things like that, and without overly focusing on those people, but kind of giving some information, providing some access to the information. um can this happen to somebody with healthier lifestyles? Can it happen to somebody with healthier habits? Right, I'm sure sleep and stress factor into it, but um in training and in fitness, a lot of the time, I won't say a lot of the time, that's probably too aggressive, but there are instances where I've seen very, very similar issues from things like under eating and just really rapid metabolic decline from I would say inconsistent consumption and things like that. So without leading you or anything like that, is it always going to be these people who are like taking in too much and putting out too little, or are there other instances where this can happen?
So, so that's a great question. There certainly, yes, there are other things that impact insulin resistance other than just activity level and dietary intake. Certainly, genetics plays a role,
Hmm.
unequivocally. like you said, sleep, stress, all these things.
Sure.
Certainly. In the vast majority of cases, it's people who are, not doing enough physically, taking in too much in terms of carbohydrates and calories. It is not That's not 100% though. It like you said, there are cases where people who, their phenotype is someone who looks fairly fit and robust, but they have insulin resistance. Um, that is certainly far more the exception than the rule. But just because you look at yourself in the mirror and on the scale, you're looking in a healthy range, or on one of our in-body scans, you're in a healthy range, does not necessarily mean that you're in the clear. It's certainly better to be there in terms of just risk profile than to be, have a BMI over 40, say, or something like that. Um, but it's not the be all end all of insulin resistance. And so making sure that, I guess even in someone who looks the part, as you said, or even in someone who's like, hey, I'm actually probably taking in less than I need and probably exercising more than I need, perhaps. Certainly, yeah, it'd be more rare for that person to have insulin resistance, but they're not, it can happen.
Sure.
Um, mhm.
I would assume because it's kind of a signaling situation, right? If you're doing too much cardio, so like too much running or whatever the case is, and I would define too much by like basically how much you can recover from and then how much you consume, and then kind of butting up with not eating enough to sustain that, but you continue to do it. I would assume, without having a ton of medical knowledge on this, that the signaling might work in the opposite direction, right? Like, yeah, you definitely want to hold on to as much of this glucose as possible because we're not getting very much. Um, and I can see that, being classified as insulin resistance just for very different reasons, right? But I would assume that that's quite rare and probably linked to other issues.
Yeah, no, you're absolutely right. Anytime there is a situation, just to kind of simplify it, where the uh, insulin levels are too high for too long of an amount of time, and again, the vast majority of these cases are from what we talked about. But if anytime it's a signaling hormone, in this case insulin, for that's too high for too long of an amount of time, you'll build up this sort of tolerance or resistance. Um, so yeah, that's a fair point. There's more than one way to get there. Um, but I think just clinically, what we see, 9 times out of 10, is patients who are eating too much, exercising too little, or both.
Yeah, yeah. And I think those are the uh important ones to focus on. I don't want people to be like, I do a lot of running. I don't eat very much. Like I don't want people to get
Uh-oh. Yeah, no.
concerned. Yeah,
Right.
that's very unlikely to be your
Right.
problem if you were those things I would attribute as to the healthy column. Yeah.
Mhm.
Um okay, so continuing to focus on our on these behaviors and on this kind of like, too much in, not enough out, as just like the core of it. Um, People are going to start to feel, you know, I would say crappy is maybe the most appropriate way I could put it. At some point. But I assume like many things, people have a hard time figuring out what's going on with themselves, right? We don't encourage people self-diagnose. We encourage people to have conversations about, what's appropriate at baseline, as far as like sensation or experience, right? But that being said, kind of observing those things about yourself is the first step towards a diagnosis. And so what sort of things um like symptomatically occur when a person has insulin resistance but doesn't necessarily have diabetes?
So that's a really good question. Um, Along the theme of our prior episodes, symptoms can be very nonspecific,
Hmm.
which again makes it very difficult because
How strange.
you wake up and you're tired and you're like, oh shoot, was this sleep? Was this my thyroid? Was this my hormones? Was this my insulin level? Like it's almost impossible to tell. Typically, though, with insulin resistance, it's typically a silent disease. You're typically not going to get many symptoms, like overt symptoms, you can actually still probably feel okay and still have insulin resistance. It's not going to be one of these things where you're coming into a clinical encounter and your chief concern is, I'm tired, I'm losing energy, um, I I just feel kind of mentally foggy, perhaps. And the first thing that comes to mind is certainly not insulin resistance.
Mhm.
There are, perhaps a sign and less of a symptom, less of a something that patient necessarily might feel, but more of a sign of this is something we would call central adiposity. So when individuals come in and they have the proverbial beer gut or a lot of fat stores around the center,
Mhm.
like love handles around the belly or on the abdomen, that is often a sign that there is some visceral fat as well, and that can be a sign of insulin resistance. And so in those patients, we're a little bit more uh, clinically suspicious of insulin resistance along the spectrum of a metabolic disorder. But it's very difficult to, I would venture to say it's impossible to diagnose this purely from a clinical standpoint, just based on symptoms.
So is this something that you would screen for given the vagueness of all of the symptoms?
Yes, it would be part of the workup certainly for this would be, what is, and granted, like you said, there may not be prediabetes or diabetes or even like an abnormal fasting blood glucose, but
Sure.
those are things that we would check typically first. Um, and then we can get into some of like the other, I suppose this is as good a time as any to talk about the like how we actually do diagnose this kind of more
Yeah,
specifically.
let's do that.
And we can actually directly measure your insulin levels in the blood. We can actually measure your insulin's response to glucose at certain times. So we give you a really sugary drink, typically about 75 grams of glucose in this really sugary drink, like what
Gross.
women get in like a gestational diabetes screening test if you're
Sure.
pregnant. So it's a disgusting drink. It's called glucola, is one of them. It's just so sugary, and that will raise your blood sugar because you're taking in all this sugar really quickly, high levels. Your insulin should respond at a certain period of time. And typically, this is done for no more than 2 hours after the test. Like we do at 30-minute intervals, usually around 90 minutes. Some people go to 2 hours. It's kind of test preference, but we'll check your blood sugar and we'll check your insulin and we can compare the two and see, okay, does your insulin rise disproportionately high to maintain a blood sugar in the normal range? Or are we seeing like, yeah, actually, even with mild to moderate amounts of insulin, you're able to keep your blood sugar in an expected zone? So we can do that specifically if we're really concerned about this, about insulin resistance. We may also see um, people have signs and symptoms of what we call fatty liver. And when the insulin levels in the blood are really high and the muscle is kind of like rejecting uh, insulin signaling to take up more glucose, the liver will kind of pick up the slack and will take in the extra glucose. But in doing that, it creates more fat, and so you'll get fatty stores in the liver, and that's called metabolic associated fatty liver disease, or MAFLD is the acronym that we use now. And some signs and symptoms of that are liver enlargement. Either you can sometimes feel it on a clinical exam,
Sure.
or on blood work, you can see the liver numbers, the AST and ALT, something we call the transaminases. These are markers of liver inflammation. We see those numbers rise. And so that can be an early signal of hepatic inflammation, liver inflammation, as the fat deposits in the liver, even if someone has a normal A1C and fasting glucose.
Mm.
And then sometimes even on imaging, on ultrasound or on CAT scan, sometimes found incidentally, but we can actually see if a liver has fatty enlargement. So that's another way we can diagnose it. But so we can do it a few different ways, and sometimes a combination of all of them. But the best test and the one that's kind of the gold standard for insulin resistance is having someone drink the nasty sugar drink, measuring their blood glucose and their insulin at 30-minute intervals thereafter, and seeing what response we get.
Okay. So, um, like like past episodes where I say that as though we've been doing this for years. Um, It's important to continue to highlight um how the patient physician relationship works, right? A good physician is going to go after a few things at once to essentially cross them off the list to determine how deep do we need to dig on this, right? And so obviously, some of these symptoms sound like many things, right? A lot of the causes sound like many things. Um, and so being patient while that happens, I think, is really, really important for the patient and the provider, right? Because you don't want to work with too much information. And that's where I wanted to kind of transition this a little bit to talking a couple of people off the ledge, for the lack of a better term, because I, I can't tell you how many times in my career alone that I've had people insist, who are healthy people, everyday normal stuff, um, insist that they're insulin resistant, but their doctor just won't listen to them or whatever the case is. And without doing any of these tests, it's, you can't really prove it. So it's always this like boogeyman, kind of in the just waiting for you, it's just in the back, like, oh, I might be insulin resistant. Um, and the reasons that I've heard are usually things like, I can never recover from my workouts. Um, I'm not building any muscle. I'm not burning any fat. And the problem with this, at least from my perspective, is that all of these things are correlated, but not necessarily causal, right? And I say that because all of these things are also environmentally driven. How hard are you working in the gym? Well, that's subjective. How well are you sleeping? How much are you eating? Are you eating the appropriate things? These are all really, really difficult things to measure from the outside. You have to be not only educated, but have appropriate context and be extremely honest with yourself about these things. And I just think that a lot more harm comes from assuming that you have a medical condition rather than seeking out information and try to build some context for yourself. Because all of these things are very subjective and vary greatly, because I don't know how much any person knows about what is the right amount of food for them, or what is good food for them, or what does recovery even mean for them. And so I just want to talk some people off a ledge and encourage that they, again, continue to, one, be patient, but seek out relationships that are based on communication for these professionals, right? Find a good gym, find a good physician who's willing to field these conversations, but also be honest with you about like the difference between these things. Getting testing, there's no harm in getting testing. But if that's your first response to everything that is troubling you, you're going to be doing a lot of testing and drinking a lot of disgusting drinks.
I listen, I couldn't have said that better myself. I think that is fantastic. And I think even if it's not like the quote unquote perfect diet, not the quote unquote perfect exercise routine, this is exactly a situation where we don't let perfect be the enemy of good. And so
Nice.
doing something is far better than doing nothing and being just paralyzed by making sure you have the optimal conditions to start. From the standpoint of insulin resistance specifically, yes, you're right. We can test for this. Oftentimes it is overkill. The other piece of this, which is really important, is it's it may not change our management, right? We're probably still going to recommend that you're eating, not super high calorie and carb diet. We're probably still going to recommend that you're maximizing your muscle mass. We're probably still going to recommend you're exercising and avoiding being sedentary. Like these types of things are the bread and butter of extending health span. We're going to be recommending those things no matter what. And
Mm.
so if you're concerned that you're quote unquote insulin resistance, okay, are you maximizing those areas of your life and doing as good of a job as you can do? If so, and you're still concerned about it, then perhaps we can test at that point. But it's not, you're right, it's not the first thing that we would jump to to kind of determine whether whether you have this sort of insulin resistance or not. So, but I fully agree with you. I think um, I think you said it very well. And you see it a lot, especially with people that you've been training, I'm sure.
Yeah.
Um, which is, and it's not most patients, but it's certainly some, and and they stick with you.
Yeah, and it's people want to see good results and they want to see the fruits of their labor, right? And when they don't happen, I understand, it's hard to decide, is what I'm doing enough? Am I working hard enough? Am I being honest with myself? I just don't want people to jump to the conclusion that something is wrong with them, right?
Right.
Behaviors can be changed as long as you're willing to change them. Once you start getting down the road of testing, I think we've illustrated that's a deep rabbit hole that you can just keep going, and it's not always going to be tangible or useful. But we can just keep doing it, and you can
Mhm.
just scare yourself to death, for years, really.
And there's a lot of people, a lot of providers out there who claim to have the answer. They've got the magic pill, they've got the workup that you need. And a sort of a heuristic that I've developed over the years is that the more certain a provider is that they can do XYZ, the less capable they are of doing that.
Oh
And
man.
so just there's nuance to everything. And if you're seeing someone for the first time, they're like, oh, this is clearly your problem. You are deficient in this specific exercise and this specific vitamin, and here is my regimen I'm going to give you. Uh, Run away. If we're
Yeah.
doing that, run away. I don't think we do that here, but there's certainly a lot more nuance. But the more certain someone is that they have the answers to all your troubles, the less likely that is to actually be the case.
Yeah, humans are complicated. Yeah. I don't know. I don't know how much certainty I want a person to have. I want my physician, I want my trainer, I want all my service providers. I want them to be curious, right? And
Hmm.
and willing, you
Yeah,
know, attentive maybe, but that's certain. I don't know if I believe in that.
right.
Uh, so let's do this. I love the opportunity to allow people to walk away with something practical, something tangible, a real go do this sort of scenario. Now, I'm not suggesting everyone go do this. It's if you believe that you fall into the column of this is relevant to me, then let's make this useful for people if they are suspicious that they could be insulin resistant, they fall into the behavior categories, they're getting some of the symptoms, they're having a hard time with some of those kind of fringe things like recovery, etc. What are some questions that they should ask their physician in order to ensure that they're on the right track and essentially begin the necessary protocols or testing?
It's a great question. I think it starts, especially if you're going to see a physician, it starts with the basics. It starts with an evaluation of your symptoms, certainly a comprehensive history, just to make sure there's not something else going on, right? It's just we're not attributing your symptoms to insulin resistance when they're actually caused by some other disease state. So
Mm,
that's important. But assuming that you're normal in all other aspects and there's not a clinical suspicion of something else, it really starts again with the basics of what we would call more of the objective data. So things like, is your weight in a generally healthy range? Is your muscle mass high, low, or kind of in this like I think it's probably more binary to be honest than that. I think it's either your muscle mass is either adequate, meaning it's high or moderately high, or it's suboptimal, meaning it's
sure.
low or anything below that. So kind of more binary is how I like to think of it. And there are very easy ways to measure that. We can do that in our clinics with the in-body scan, which takes 20 seconds. But starting with those base, so are you have a healthy weight and like kind of just body phenotype? Do you have adequate muscle mass for your age and for your kind of size? And then looking at even just starting with basic blood work, things that would probably be you'd already have gotten, things like your A1C, your fasting blood glucose, your liver enzymes, making sure that those are not only in a good range, but optimal within that normal range. So you're not like at the high end of normal, but like pushing high, right? That you're in actually a rock solid normal slash low reading on those. um, to kind of make sure that you're in kind of an optimal state. Um, and blood work can get as nuanced as doing the oral glucose tolerance test with insulin, but that's often not the place we would start. And I think just asking the question to your provider of, okay, if you were in my shoes, if you were me, doc, what would you do? What would be the first steps that you would take to, you know, I guess decrease my chance of insulin resistance or XYZ? Asking the doctor, put kind of, if they were you, have some skin in the game, what would you do if you were in my position, I think is a very valuable question.
Mm.
I think most patients having at least even if they feel like they've been training all their life and they're fantastic at it, having the conversation with one of our trainers, I think is a very worthwhile exercise. And sending them to someone like you, Derek, and saying, okay, are they actually doing what their goal, are they on track to achieve a certain goal? And that's probably a personal goal. And then from like the standpoint of like me as their physician, are they doing the things they need to do to maintain this adequate slash high muscle mass? Because not only metabolically, but musculoskeletally, it has implications with health span and being able to live a long, healthy life more than just insulin resistance.
Yeah.
And so I'm curious, like, if I say we get this patient, Jane Doe, and she wants to, increase her muscle mass or she's worried about insulin resistance, I say, all right, go see Derek. What are kind of, I've kind of gone through what some of the questions are, some of the testing is for insulin resistance, but from the standpoint of using more, building more muscle, what are some of like, I guess, the low hanging fruit that you see as like areas for people to take advantage of?
Yeah, I think one of the most obvious ones when people are talking about insulin resistance, just kind of general health span things. I think one of the most obvious ones is like when we do an in-body, I don't really care where your weight is right now. I want to know how much muscle mass you have, and I also want to know about the distribution of that muscle mass because it's unfortunate and it is like kind of almost a cliche at this point, but everybody's skipping leg day, John. Um
Legs,
the
but the legs aren't important, I thought. I thought it was all about the glamour muscles.
Specifically it's upper traps. It's all about the traps and neck actually is the new thing.
All right, Mike
Um
Tyson. Yeah.
that's right. And a lot of people really, really lack skeletal muscle in their lower body. And when it comes right down to like function and utility, you cannot afford metabolically, functionally, performatively, right? You cannot afford to have very little or insignificant lower body muscle mass compared to other areas or at all, right? You need to really take advantage of that. The muscles are enormous in your lower body, which is, part of the problem. They're big and they need a lot of work. And when they get sore, they hurt everywhere because there's only so many of them. And they're, they do very similar things. But that's one of the first things I look for is there a legitimate discrepancy in muscle mass or strength in the lower body? And when people are kind of in this like type 2 diabetes category, or like, maybe they're insulin resistant, or maybe just like they're struggling with, their goals in general, usually it's because they lack a tremendous amount of lower body muscle. And I get it. It's easy to ignore because it's hard to train. You got to work really hard, and then then they're sore, and you want to sit on the toilet and it hurts. I get it. That's a big one for me. I like to look there first. Another one is kind of a random one, I think. With regard to try not to say so many times. There's a weird energy system that people don't talk about that handles things like elastic recoil. And it's like really prevalent with plyometrics. And it's essentially the reason why if you were to take somebody who is really skilled at like bench pressing and back squatting, like powerlifting style movements, and then put them into a boxing environment, it's one of the reasons why they would be they would just get shelved, right? It's not about getting punched or anything like that. It's about the type of movement and the metabolic proficiency that you require in order to sustain that type of movement over a long period of time. But it has a lot to do with um output and absorption. So like that kind of recoil elastic style movement. And we lose that as we age a lot. And it's a big factor in energy management. And it's a, you know, I'm going on a tirade here, but it's also a big factor in people's injuries, right? We essentially lose the ability to produce power, right? We lose the ability to jump and extend our hips rapidly. And that's another without going taking this example too far, that's another thing that I see a lot when people have issues with sugar. You know, they almost always fall into this bucket of like, not only are you lacking muscle mass in specific areas, but you're also lacking baseline function in many areas. And it's a legitimate energy system. It's a way in which you can improve and utilize energy and specifically glucose pretty easily. And it would also increase your health span quite a bit because you would be injured less. You would be able to do a lot more things. You would have a lot more flexibility and
Yeah.
mobility.
And
So
that's
those are,
actually no, that's a great point just to piggyback on that. That's one of the reasons why not just doing cardio as you live longer is important because
yeah,
these type 2 muscle fibers, these kind of fast twitch muscle fibers will atrophy and you'll
very
lose them.
quickly.
It's like it's almost the definition of if you don't use it, you lose it. And that's like it sounds crass, but it's true, especially within as people live longer from a muscle standpoint. So and, you know, you're talking about something that's obviously a little bit more complicated than that, but to just distill it for, you know, plebeians like myself, like you got to use it, otherwise you lose it. And that includes the muscle strength, that includes fast twitch, that includes working on things like balance. I mean,
Yeah.
it requires a more comprehensive approach than just, I'm just going to hop on the elliptical for 30 minutes a day, uh, break a sweat, you know, get my heart rate up.
Yeah.
That's good, but
It's a
it's
great
not
start.
everything.
It's a great start. I've done talks about diabetes before in groups, and I've been, you know, asked to conferences for things like that. And one of the things I constantly say is like, you know, people always want to know, well, what can they do about it? How do you start? And I honest to goodness, I really believe it. Like just start walking, just start doing something because it's just about like, you know, it's the low-hanging fruit, like you said, to start. And when you win, when you succeed in these little habits, that's where motivation comes from. Motivation doesn't come from like this spark one day. It comes from success. And so you just got to find a way to win early. Um, Obviously what I was talking about is a bit more complicated, but just to kind of like, you know, put a nail in it, it's really predictable the way that people start to degrade. We can kind of see what's going to happen next or, you know, what really needs to happen in order for them to improve, right? Without skipping steps. And that's where your point about uh you know, even if you're accomplished, even if you're an athlete or a former athlete or you've just been working out for a really long time, I've been doing this for about 20 years. You know, I'm as accomplished as one can be without being a professional athlete. Like, I know a lot of things. I still use coaches. Professional athletes still use coaches. Making decisions in an echo chamber is seldomly a good choice. And I think the smartest people in the world will leverage the perspective and collective knowledge of others. And so don't sit there and be like, I know exactly what I'm doing, but even though I'm not getting the results I want, like, don't be so proud as to not have that conversation with other people who are as or more accomplished than you. And that goes for like talking to your physician as well. Like, don't be so proud that you just can't ask these questions.
Yeah. There's a famous saying, the physician who treats himself as a fool for a doctor. And I think that's applicable to widely. But just a pitch for a book recommendation based on what you were talking about is Atomic Habits by James Clear. Is kind of like the basically the gist of it is start small. Start with something like an atom-sized habit, right? Something that's so small it's the size of an atom. Um, and so that's a good book for anyone who's interested in habit formation. But your point is is a fantastic point.
That's an elite level book recommendation, Doc. Solid. You're always good for a book recommendation, that's for sure. Okay, so where do we go from here? I feel like we covered a ton of things. We made it very, very practical. It feels like the long-term conversation here is obviously taking care of yourself and being objective about what your day-to-day habits are. And, without, shaming people per se, right? I do think like some degree of accountability is necessary to avoid things like this. Anytime you can say that a particular disease or symptoms of pre-disease, I guess is probably the way I would explain it. Whenever you can say that they are behavior and environment driven, you have to take some accountability if you don't want to feel like garbage, if you don't want to have to go through the long-term negatives of whatever treating this is. So where do we go from here for people?
That's a good question. I think it's really just, again, even if you are, just to kind of reiterate some of the points that we had made before. One is don't let perfect be the enemy of good. So starting somewhere. Two is that even if you're concerned about, do I have or do I not have insulin resistance, it's very well known how to improve that with lifestyle modification, right? With decreasing the, glucose and carbohydrate and calorie load in and increasing the exertional output on that side. So kind of maximizing both of those aspects of your lifestyle is really important. I think three is if you are lost and you're kind of paralyzed by like, okay, where do I start? I know I want to do better, but where do I start? Have the conversation with your, friendly neighborhood physician, whether that's one of us at Active Health or, your trusted kind of neighborhood doc or healthcare professional, I think is a good place to start. And yeah, I think it's again, it's a little bit more of a nuanced conversation, but by and large, it is again reversible. It is something modifiable. And in the case of, hey, you've done everything right, you still have insulin resistance, we have really good medications as a kind of a last step to treat these kinds of things. The proverbial GLP-1 agonists, we have SGLT2 inhibitors, we've got TZDs, we've got a lot. Hopefully it doesn't come to that point, but if it does, it does. So it's never too late essentially to start thinking about this or to treat it. And so kind of just starting somewhere, I think is the main takeaway, at least from my standpoint, from this conversation.
That sounds great. I mean, it feels, not to diminish anybody else's experience, but it feels really straightforward. And all you got to do is remain objective and take, make some forward progress. And this doesn't have to be a thing that you deal with. So, that's what I have for today. Unless you have anything else, Doc, I'm good to go.
No, I think this was a great conversation, and I look forward to talking about this more with patients and seeing what questions anyone has about the topic today.
That's awesome. I'm going to end with, look, guys, metabolic health is ultimately built over time. It's not something that you hack. And it's definitely not something that you make panic choices over. With that being said, I'm Derek. That's Dr. Jon.
Amen.
Thanks, guys.
See ya.
Bye.